I am no neurologist, no epilepsy expert. I am a pediatric gastroenterologist. I lead the nutrition service and I look after these children from the gastro and nutrition point of view, supporting Helena's team, especially for difficulties when these kids do not want to eat. And you know Helena very well, so you don't have to. Okay, so this is just to set a scene, just to remember that the incidence and prevalence of children with neurodisabilities are going to increase. And this is due to the very high level of expertise in our NICU. So we are able to resuscitate and prolong the life of a lot of children that a few decades back would have died in the first few months of life. So we have actually to deal with these children more and more from all perspectives. Before we move on to some case reports, I'd like to give you a little bit of a background of what I do and why am I involved in kids with neurodevelopmental conditions and that might benefit from ketogenic diet. So you've heard about the brain-gut axis. Everyone talks about it. It's very famous. But maybe I might actually be able to give you a little bit of context and explain why the symptoms you see in your patients are actually, not surprisingly, correlating gut and brain together. We will also show you some experiences we've had with children and how we've overcome their feeding difficulties and how we manage their nutritional needs. As I usually tell in all the teaching that I do on nutrition with this group of patients, but nutrition in general, it's not a recipe that fits all. This is all about mixing together different expertise and different intervention to be able to achieve the best for that specific child. So it really, intervention and management is patient-tailored. Okay, so down to the business. I hope you're all awake. So enteric nervous system is the nervous system within the gut. It's also called intrinsic nervous system. It might sound most familiar for some of you. So it's really highly densely populated. And we always say to patients, the gut has more nerves than the spinal cord. And that, you know, maybe it's something they can actually relate to. So the enteric nervous system is innervated by the autonomic nervous system. But it can also operate independently from that. Some of the function of the gut are completely disjointed from what the autonomic nervous system commands. So they're not linked with the brain or the spinal cord. They're autonomous. I'm not going into this, don't worry. Just to give you a hint of how complex it is, understanding the gut physiology and the gut neurophysiology is really complicated. Even gastroenterologists don't understand it. So hey, I've said it all. We're not the smartest in the bunch, I'm afraid. But what I'd like to actually draw your attention to is the gut is really complicated. And there's a lot of interaction, a lot of neurotransmitters that are going back and forth from the gut to the brain. And it contains a lot of the serotonin and the dopamine of the body. So it is an important part of the nervous system. Just maybe you know, some of you might actually benefit from a more visual, I certainly do, more visual perspective. So the gut takes part in both the rest and digest and fight and flight reactions. So basically what it means is both the two branches of the nervous systems are the sympathetic and the parasympathetic are actioning within the gut. Basically it means that the gut does everything and there's the opposite of everything, which is making our work really straightforward, as you can imagine. So, to clarify it and make it really, really simple. So the autonomic nervous system modulates the nervous system within the gut. That's simple. If you have any problem in your central nervous system, any disorder, condition, disease of whatever sort, by default, that goes and affects the way that the autonomic nervous system modulates the gut nervous system. So what does this mean? In a nutshell, it means that if you have a neurological condition affecting the brain, the gut will pay a price for it. Most of the symptoms that patients will have are what we call the foregut. So anything that goes from the mouth to the first part of the small bowel. Symptoms can be oromotor impairment, dysphagia, for example, oroesophageal dysmotility, gastroesophageal reflux disease. Antroduodenal dysmotility means the ability of the stomach to empty itself into the duodenum, retching, and so on. But also these patients suffer very often from constipation. So all this has a neurological background. So they're not just lacking ability to move and do physical exercise or not having a right diet. These patients are geared up to have problems in the gut as they have problems with the brain and the nervous system. So patients come to my service when they are failing to thrive for whatever the reason. And usually, as you know, knowing this patient better than anyone else, it's a combination of factors that are actually acting on that. They might not be able to eat. They might have some motor impairment, making for them difficult to have a functioning gut. But also they're very, sometimes they are impaired and they can't communicate when they're hungry, when they don't want to eat anymore, and so on and so forth. There are not many studies on feeding and neurodisabilities done in the UK. This is a very good cohort study done many years ago, about 20 years ago, unfortunately, but that's the best we have so far, and was a census. It was actually the Oxford Feeding Study 1 and 2. The one was more a census, how many patients with neurodisability do have a nutritional problem, and not surprisingly, it was quite a high proportion, but also the second part, trying to break down what is that actually they're lacking. And I think this is quite interesting. They look at all the micronutrients, but actually what they really lack was energy. Simple, very straightforward. So this patient might have an inadequate nutritional intake, and the reason for that are very complex. And more than once, there are more than one reason due to this. I'm not going through all this. I want to give you an idea how complex it might be to identify a specific reason for a patient. I think there's usually a combination of things. That's why we're trying to work in an MDT setting where we can help each other, helping the child.
So this was our first superhero. She came for her assessment. She's a child with lissencephaly, has multiple different types of seizures. She had intellectual disability and a left-sided dysplasia with osteopenia. She was on lamotrigine, sodium valproate, clobazam, and she'd come off phenobarb. So from the UK perspective, she's tried at least 2 targeted drugs and not had control of her seizures. And so we would be looking to think about ketogenic diet therapy. Socially, she was the second youngest of 9 children. And what was really striking with this family, I'll always remember them, they all looked incredibly like brothers and sisters. They were so similar. Mum and Dad had separated. We only had Mum at assessment. Normally we like both parents there. But the added complication here was that there was a court injunction out against Dad so that he couldn't come within 100 yards of, or meters, should I say, of Mum. So we did our assessment. This child loved to drink milk. She loved eating scrambled eggs, yogurts, and sandwiches. Mum made a homemade cooked meal with a pudding every evening, and she had a milk-based drink before bedtime. So, what ketogenic diet might you go for this young lady in your centre? Any takers? MCT diet, which is what we did. We went for the MCT diet. She loved drinking milk, so we could put a MCT emulsion in that. Mum was making a homemade meal, and because she liked sandwiches and yogurt, we at least would allow some of those foods to remain if we had MCT fat in there. We decided to start this child in hospital because we wanted Dad to be taught as well as Mum, and we wanted them both to have that opportunity. And so we arranged a 3-day admission, which was actually 5 weeks later. So on admission, we found that this young lady's eating and deteriorating had markedly decreased from what was described to us in clinic 5 weeks earlier, and she was now very reluctant to drink, and the amount of texture that she had in her diet had reduced significantly. So we sought a speech and language therapy review, which came back as, while she appeared to manage the food safely during the assessment, feeding remained slow and effortful, and she is likely to achieve her nutritional medicine needs, including ketogenic diet, orally without supplementary nutrition. So, what would you do? You've got a child, they've come in for a planned start on a ketogenic diet. We've chosen the MCT diet with lots of lovely textures and swapping in and out. And now we've got a child who doesn't eat that variety of food.
Come on.
Are we going to send her home?
Fire.
No. Keep her in. Good. We did.
Good.
What we decided to do, we would thicken up her fluids. We're on the MCT diet, so if we used a gum-based thickener, we haven't got too much extra carbohydrate coming in. We thought we could manage that. And a nasogastric tube was placed for her medicines and some fluids as required. We thought if, because her seizures had deteriorated while her eating deteriorated, because she hadn't been taking her medication, so seizure-wise, she was in a much bigger pickle than when we first saw her. So our aims were to establish oral food intake. We were going to use water, MCT, milk mixes, and meds via the NG tube. So we did our teaching. We were quite happy. This is her growth chart. So the arrow is where the nasogastric tube came in. And as you can see, if you look backwards of that, we've actually got a very flat growth chart, which we didn't really pick up on, and that probably indicates that this child had been struggling for a while, and we just really picked up with it on that admission. And once the nasogastric tube went down for our supplementary support feeding, her weight moved back up on where it should be. So this young lady then went home on the MCT diet. She got beautiful ketosis. She got an improvement in her seizures. She was having her meds. But then Mum, we were hoping, because we're optimists, that when her seizures got better control, her eating would improve, because she had been eating much better at least 3 to 6 months earlier, if not 5 weeks earlier. But then we get calls from Mum saying, we're now putting all the MCT milk down her tube in the morning and in the evening. We're doing a lot of her fluids down the tube. Very little is being spooned in, thickened. And she's really, although she's enjoying her evening meal, lunchtime is difficult. And could they put a feed down the tube, the nasogastric tube, at school rather than having to eat her school meal? So we decided that seemed reasonable. So our choice is, do we carry on with that lunchtime feed on the MCT theme, or do we move to a classical pre-prepared feed which can be put down the tube? What would you do? Any takers? Yeah, so we decided we actually used Ketogenic down the tube at school, so that we didn't have to actually eat at school. And that worked really well. Now, this child goes to respite care once a fortnight, and so she leaves home maybe at the weekend, goes off to respite care, and goes straight to school from respite care. And we have got going to school in her bags of Ketogenic, some Liquigen as our MCT. We have got a written school plan for the school to follow. They know they're putting Ketogenic down the tube, but it was a busy Monday morning, and we get a call saying, we've just put down the majority of 250 mils of Liquigen down this child's tube, and she's looking a bit green down the gills, and we're expecting her to vomit shortly, which she did, and she was actually very poorly for about 3 or 4 days, lots of diarrhea, lots of abdominal pain, lots of food coming back and not a lot staying down. So we decided we would transition to the classical diet at this point and not have a mix-up of products. She was less able to eat orally, and at this point we were looking that she was having a worsening swallow, it was tiring, and we weren't going to be achieving her getting back to eating those beautiful textures that were described. So our targets were nasogastric tube feeding to support her oral her some soft pureed ketogenic foods when she was out, and we actually used keto, she still had her evening meal as a classical meal now made by mum, and that worked well. And we made a referral for a gastrostomy.
To comment on that, so what do we do when a child can't feed anymore? So I'm going to briefly talk you through the feeding development and what are the indicators for assessment and what kind of assessment we would do in this case. So moving from the infant suck, which is completely reflexive, there's no acquired ability there. You're born with the instinct to suck. You have to move through first bit of your infancy, so usually the window is about 8 to 12 months of age, to acquire a more mature, voluntary reflexive, complex, integrated swallowing function. So there's a lot that a child has to learn to be able to do the basic few actions that are allowing swallow. So it's biting, chewing, formation of the bolus, and pushing the bolus backwards into the pharynx. Looks like very simple. We're all doing it several times a day when we swallow our saliva and when we eat our food. But actually, it involves a lot of reflexive, protective reflexes to protect your airways, and also needs a level of neurodevelopmental ability that some of these children do lack. So in technical terms, we divide up the swallow in 3 phases: the oral phase, the pharyngeal phase, and the esophageal phase. So what I'd like you to remember, if you can, looking at the graph, is what the bolus does once it's formed in the mouth and go at the back of the pharynx. That's the moment where we don't breathe anymore because the epiglottis is closing our trachea. And then the bolus goes into the esophagus. The esophagus, on lateral projection, is at the back of the trachea. Okay, so it's going to be useful later when we look at some video fluoroscopies. What does compromise the swallow ability at all levels is the behavior, attention level, your social learning. So what you've learned as a child, if you've been exposed to difficult textures, if you've been able to actually move on to eating more complex things, but also having the coordination, receiving feedback from the back of your pharynx, from your mouth, when it's time to move on to the next phase. It's all very instinctive. It's like driving the car. You don't even think about it, but your brain is doing it all the time. So a lot of children with congenital or developmental abnormalities, so all the diseases you're looking after, might have a dysfunction in this process. And don't forget that the first bit of the swallowing tube is actually covered by red muscles, and they are the one that in some neurological condition can be affected and deteriorate fast. So we call dysphagia the inability to move on to swallowing properly, for whatever the reason. So it's a big umbrella that compromises some organic problems and behavioral problems as well. We are here talking about dysfunction, so the inability to swallow because of neurological problems. So what are the red flags? Where should you think about dysphagia? Lengthy feeds, lengthy meals. This is the first thing that happens. The child takes forever to be fed. It takes a huge amount of time. Meals that are lasting for 45 minutes, an hour and a half might sound normal to a parent of a disabled child, but it is not. It's a sign of discomfort and inability to do a good job at swallowing. Excessive drooling of their saliva is another indirect sign that actually the swallow is not that integrated. The kid who has delayed milestone achieving in terms of swallowing, so they're not able to move on to bite and dissolve about 7-8 months of age. They're not able actually to get finger foods in a mouth. They're not able to manage crumbles, or they're not able actually to drink from an open cup. And they always need to sit on the bottle or the beaker with a soft spout. But basically, they keep sucking instead of actually managing the fluid in their mouth. Of course, if the child has recurrent chest infection, you would always think about a problem with their swallow. But it's not usually the first sign. And there are kids with observed aspirations. They don't get many chest infections. They might have compromised lungs, but they don't always get aspiration pneumonia. So it is a sign, but if you wait for that one, you might wait for a long time. And of course, a child who's not growing very well because of all this already should actually think about, if the calories offered are there, is the child actually able to get them into himself? So the speech and language therapists we work with, and I'm sure it's in your teams as well, would look at all these things. They may maybe call them in a different way. They would call them repeated swallows. That's something you might have heard about. Or tongue thrust is when the child is pushing the spoon away instead of actually accepting it. And of course, they can cough, choke, they can drool and lose food or fluids from the front of the mouth. All signs of an impaired swallow. We would always get a speech and language therapist to review this child. She actually sits in clinic with me all the time. And she looks at certain signs that we do, again, without noticing. Our jaw is very stabilized when we chew. Kids with neurodevelopmental condition might have a problem in stabilizing your jaw. They might be doing better if someone holds their chin up like this. Chewing is not great. They can't lateralize the bolus. They can't move the food from one side or the other or the mouth. And these are the signs that she should look at. Of course, we can always do a video fluoroscopy when we have concerns. Always? No, not always. There's one requirement to be able to do a video fluoroscopy. The child has to be able to drink or eat. You might be surprised by how many requests I've had for video fluoroscopy in children that are unable to take anything for whatever the reason. So they're nil by mouth and they want a video fluoroscopy before starting any oral intake. And you think, hold on a minute, no, can't work. So this is actually can happen. There are compliance issues. These tests are done by the children sitting on a special chair. What you see there is a foam chair for smaller kids. The bigger kids should go in actually in a even more frightening chair with a lot of straps, and they need to be able to stay quite nicely upright. We can't have anything holding their head, because otherwise you wouldn't actually see much on the video fluoroscopy. So, anyone is familiar with video fluoroscopies? No? Cool. Actually, I was counting on that, if I can get my video running. So you can see that the baby suck. The fluid is pushed at the back of the pharynx and gets into, does he have a pointer? Yeah. And gets into the esophagus really nicely, right? It's a good coordination. The baby's keeping a good pace, trying to breathe in between sucks. Fantastic. This is what we like. I'll show you something very abnormal. And trust me, you don't need to be an expert to see that. So it's pooling in here. Can you see the sort of linger around? And here we are. This is an aspiration. What is really worrying about this baby, the baby's not coughing. This is not a good sign, right? But this, I hope, was clear enough, yeah? And then I'll show you what more often we see, which is the effects of fatigue. This is a normal swallow with a delayed aspiration. That was most of our patients do get. So the baby starts off really well. There's a little bit of coating of the back of the pharynx. It lingers here a little bit longer than usual. And then after a while, after a few sucks, when the fatigue gets in, you'll see an aspiration going in. Can you see it? It's going to come now. Yeah, there's a little bit. Here we are. Can you see this? So it's minimal. It's not really, it's a little bit subtle if you want, but already this pooling of fluid on the back of the pharynx. Here we are. Did you see that? Yeah? And now we have the baby coughing. Yeah, didn't like it, thank goodness. So there are some usual advice that you can give to a child with dysphagia. Some is about positioning, thickening agents, as you normally do in your practice, trying to get the best feeding equipment. It makes a huge difference having the right beaker, cap, spoon, fork, and so on. We need to pace them to avoid fatigue. All these basically interventions that are quite common in common practice. We do have some drugs we can use. I often use some, we don't have any good motility drugs, but I use at the moment erythromycin at a very low dose to try and use the prokinetic side effects of it instead of the antibiotic effects. In the UK, we don't have access to many drugs. Domperidone is completely useless. Plus, it has a heart alert attached to it. It can prolong your QT time if you are prone to this condition. So for the UK, at least, we can't prescribe it unless we have a cardiological review. And honestly, it doesn't do much in general terms, so I don't tend to use it. And we do think about tube feeding. Tube feeding is something that we do often in these children. Now, the problem we have with tube feeding is getting parents to accept it, and we'll come back to that. Nasogastric tubes, I mean, this is a chunky tube in a baby, in a neonate. It's a really big one. This is actually a surgical tube, but it's a good picture to show where the actual tube sits. It sits in the stomach, and it stays there, causing minimal problems up until they're able to pull it out by themselves.
Okay, so we have now our second superhero that we'd like to present to you. This was a young lad who was age 7 when he returned to us for a ketogenic diet assessment. So he'd been on the diet for 2 years when he was younger. He'd been very successful in terms of his seizure control. He'd come off the diet and maintained that seizure control, but over the next 2.5 years, things had worsened, and so he returned to the clinic. The family actually declined to return to the KD, saying it was too difficult for him to take him orally. So that was the conclusion, but I'd like to take you through how we got there. So when he came to us, he was eating a soft puree diet, which was not ketogenic, and it was restricted to what the family could cope with their busy family life. He had limited fluid intake, he had his seizures, his weight was faltering, and the family was struggling. But let me tell you what Mum was feeding him. Bear in mind, he'd been on a ketogenic diet 2.5 years previously when his eating had been fine. We'd had him on a classical diet. And so Mum was feeding him to keep his energy up. Avocado mash with banana for breakfast, followed by a Milky Bar pudding. I think that's Nestle, actually. I think you'd be happy with that one. He then had a homemade soup and another Milky Bar pudding for lunch. And then for tea, he had avocado matched with goat cheese and another Milky Bar pudding. So we talked to Mum about, rather than waiting for the gastrostomy that they had been sent up for by their local team, and we have quite a long wait for gastrostomies to be fitted on a non-urgent basis, why don't we try avocado maxed with some cashew nut? Let's take that banana out and do a ketogenic, sugar-free panna cotta dessert to replace the Milky Bar pudding. So here's me thinking that's not too different in terms of textures and tastes for this young man. And the family said no. And the reason they said no was they had got to breaking point. It was very difficult to feed this child. It was taking a long time. They had a plan that worked, and they weren't about to rock the boat. This was his weight chart. So the drift in weight is as he's really struggling on these really quite energy-dense mashes that his parents were giving him. And the increase in weight is probably when the local dietitian got involved and actually looked to support this family with what they were giving. So our aims were to think about reintroducing the ketogenic diet via his gastrostomy and only giving him foods for pleasure rather than him having to struggle to eat them.
We thought of giving you a bit of an idea what tubes are, because everyone talks about PEG equal gastrostomy. They're not the same, technically. Gastrostomy is any device that goes into the stomach. A PEG is a precise kind of device, which is a percutaneous endoscopic gastroscopy. So what it is. You might have seen the outside bit dangling off patients. What's inside is a disc, which is semi-rigid and sits in the stomach. Has to be placed through endoscopy. That's why it's called percutaneous endoscopic. So it is actually placed in a very simple, minimal invasive way through an endoscopy, upper endoscopy, dilate the stomach, puncture the stomach with a trocar, pass a guide wire, get the guide wire out of the mouth, attach this bumper, that's how we call it, to the guide wire, and pull him back the other way around. So basically, this is the bit that goes into the mouth, and this is the last bit. And you can push it through the hole. Sounds horrible, but it's fairly straightforward. So the external bumper, that is what you might find in place on these children when they're coming off the procedure, is crucial, because for the first 6 weeks, these two bumpers have to be kept really tight, close to each other. that's what allows the tract to be formed. The tract is the fibrotic, basically, reaction that happens when you put a tube through the skin, through the muscles, through the fat, and through the stomach, through this. So what we want is all these bits to become packed together so they can't move anymore. So what a gastrostomy does, it anchors the stomach to the abdominal wall. So that bit of stomach won't be able to move freely. I mean, it's not that the stomach is an organ that moves a lot, don't get me wrong. It's quite tightly cushioned between the liver, the pancreas, the small intestine, the large intestine, and the lungs. So it can't, and the diaphragm on top, can't go really very far. But there's a little bit of movement, especially when we do physical movement. What we do, we anchor that bit. And once we've got the tract formed, we are much more relaxed. You can get this external bumper, keep them a little bit, in a more loose position. It doesn't have to be as tight, because you know that the gastrostomy is safe. There are other alternatives of placing gastrostomy in this way. That's why you can always refer to PEG, technically. There's an open gastrostomy, so you have actually to isolate the stomach with a small incision. That's what they do. And they put the tube in, which is balloon retained. It's not a PEG. And they suture it in. So usually it's done in kids with severe scoliosis, where you can't really do the percutaneous technique. There are different types of balloon you can place in, but most of them are balloon retained, because it means that when you have to change them, you don't have to go in with another procedure, another endoscopic procedure to remove the bumper-linked device, but you can actually deflate the balloon, take it out, and put a new one in. They're called monarch gastrostomies. There's also a laparoscopic procedure that is now done by most pediatric surgeons. It involves just 3 little holes on the abdominal wall, and they can do the same thing, but with minimally invasive surgery. Of course, instead of taking 20 minutes, it takes 1 hour and a half, so it has costs involved with that. So after 6 weeks, that's why I've been banging about the 6 weeks, the tract is formed, and that's the time where you can change the long dangling tube called gastrostomy, percutaneous gastrostomy, or direct gastrostomy, with a button or a low-profile device. I'm sure you've seen them all. This is a Mickey button. This is a mini button. The difference is the size of the bit that is outside the baby, the child, okay, outside the stomach. They are balloon retained. There are usually 2 ports. One port is for feeding, and one port is for the air inside the balloon, so you can deflate or inflate. What we usually put in is saline solution, so that you can keep this balloon nicely distended, but has a sort of a bumpy effect, nice and soft against the abdominal wall inside. So that's what we would advise, because changing these devices is something that parents can learn to do at home. It's very simple. They do have a little bit of risk of exploding. The balloon can pop, especially if the child is contaminated with candida in the stomach. But it's not a big deal. You can easily change it more frequently. When you want to feed your child, you have to attach a connector to the port, to the gastric port, and feed the child normally through the connector. So it's very handy. It's really low profile. It's not seen under the clothes, and children can't tug on it. Oh, use it.
Our final superhero was a little lad who came for assessment. I'll always remember this young man because I don't know how your centres work, but we have planned assessment clinics. So this was a Friday morning. I wasn't in clinic. I'm happily sitting doing some work, and I get a bleep, and the message is, I've got an emergency ketogenic diet assessment, which for us normally means they want to start straight away, and it is Friday, and you start wondering. So I go straight down there, and the lovely consultant said, I forgot to say the emergency is I forgot to tell you there was an assessment, but it's not an emergency quick start assessment. So anyway, we're down there. It's not an emergency. We've got an assessment, and this young lad is in clinic. He has a brain injury from neonatal hypoglycemia. He's got epilepsy, including infantile spasms. He's got global developmental delay and significant visual impairment. As you can see, he's been on 3 drugs, and they're considering ketogenic diet therapy. His meal times were taking up to an hour and a half. So a really compromised swallow. And so with that, and his swallow tired as the day went on, So, what would you do? An hour and a half.
Come on, you know it. You know it.
We're going to think about
Which tube? Hey.
So we're going to think about a gastrostomy for this young man. His swallowing continued to deteriorate while he had the gastrostomy in. He was actually just taking oral tasters where they put food onto his lips for pleasure, and his feed was going back in to his gastrostomy. So actually, when we were doing the assessment, he's already got his gastrostomy fitted. The delayed feeding, the 1.5 hour meal times, had all been dealt with locally. They'd referred him up for gastrostomy. And now we're in a position to move him over to a ketogenic feed via his gastrostomy. So Dad did say to me, I do 4 feeds a day. We put them in by gravity because it's more meal-like. They're going quite quickly. If we don't have him sitting up for about half an hour to an hour after the feed, he does tend to reflux and be sick, and we couldn't feed him if he was lying down because he would just be sick all the time. So we decided we would go for a classical feed because he's going down a tube. He was 4, so we decided to make it a 3-to-1 feed. And because they had been doing bolus feeds for a day, we went for the same volume, but we're mindful that this was a higher fat feed and therefore might stay in the stomach a little bit longer, and he is prone to reflux, so we might have some problems. So, we did. What would you do? We've gone to the higher fat feed. It's the same volumes as on the previous feed, but that occasional reflux, vomit, if we didn't have him sitting up, became something more dramatic.
Come on,
What would you do?
Be brave, be brave. Come on.
We've got, it's going in this, yep. We'll prolong the time. Yeah, so instead of going in on a gravity bolus, going in over about 10, 15 minutes, we decided we'd pump it. We decided to pump them over an hour. We're still a bit vomity. We went to a continuous feed in the daytime. We certainly didn't touch them overnight because we didn't want any of that aspiration at night. It didn't work. Yeah. We'd got quite nice ketones on our ratio, so we didn't actually do that, but we could have done. Yeah. So this is his weight chart. So being fed via a gastrostomy, you see from when he was oral feeding, which was down here, he was really struggling on those hour-and-a-half time meals, struggling to meet his energy requirement. He then does better, and even though he was vomiting, we were still getting quite nice weight gain. But it clearly wasn't good for him. So, judginal feeding.
Yeah. So, judge. Judginal feeding means we're bypassing the stomach altogether. This is a nasojudginal tube, as you can see it going up the esophagus. Now, we would never, ever, ever recommend judge feeds unless you've tried all of what Helena just told you. You prolong the feeds, you make slow, nice boluses, over the pump, over 1 hour, over 2 hours, whatever is needed, chunks of 3-4 hours at a time during the day, and then eventually continuous feeds. Because judginal feeds are complicated to deliver. Not from your side, from actually keeping the tube in place. So what do we have available? We have PEG or MIC-J. So remember the PEG that we discussed before, so the long tube bumper retained. There's a version of it with an attachment at the end that goes from the stomach wall down to the small bowel. And there are 2 sizes. Usually you can get it about 20 to 30 to 40 max centimeter from the stomach downwards. You place it endoscopically. It is fiddly and it requires a general anesthetic. There's the MIC-J tube. As you can see, it's balloon retained. Same principle, has got an attachment to it. And the tube is placed again under endoscopy for the first time, or with fluoroscopy afterward. You can do it as well, so the radiologist can do it. It's placed down the small bowel. So it has to go past the pylorus, past the the duodenojejunal section, and into the jejunum. So you want it buried down. Has to do this curve, otherwise it will flip back. Having said that, it does flip back, especially because these children, as we said before, has got foregut dysmotility. So very often you've got patients having the tube back in the stomach and they start vomit milk. That's how you know it, or you aspirate milk. All these tubes have both a gastric port and a jej port. So you can feed through the stomach if you want, or through the jej. Mostly the stomach port is used for deflating, deventing, or putting a drainage bag in if they can't cope with secretions, mucus, you name it. But they're fiddling. And there are some of these children that do have anesthetic pressure. They can't tolerate anesthetics really well. And also there's pressure on the system. The NHS in England is on a standpoint. We are overwhelmed. We can't cope. So a child that comes with a dislodged PEG J that needs replacing might have to wait 3 to 4 to 5 days before getting a slot in theatre on an emergency list. It's not an emergency enough to actually get them jumping the queue for kids who have more acute problems. And this is a big issue for us. So the other option is to ask our lovely colleagues, the pediatric surgeons, to create a direct jejunostomy, which is a feeding tube that goes straight into the small bowel. On paper, great idea. You know, they can't flip back. They're there already. They're very easy to get changed. They're not balloon retained or bumper retained at all. They're a normal catheter. Yes, they need a general anesthetic and they need surgery to get them placed. So what the surgeon does is an incision, then it gets the tube into the bit of gut that he wants to access, then creates a sort of a folding of the gut around the tube to keep it in place, create a tunnel. That's how you keep the tube in place. And then, unfortunately, this bit of gut has to be anchored, so sutured, to the internal abdominal wall. If you leave it floating, it goes everywhere. The small bowel is a tangle of feeding pipes, basically, and it moves constantly. So to keep it accessible, you have to attach that bit to the abdominal wall. So what you're doing, you're playing with the anatomy. And these kids that, again, have got dysmotility. Remember that. So surgeons don't like doing this. Every time we go in and say, we really need one, they're just looking at us and say, oh, no, we're not going to do that. And it's not because it's technically difficult. It is not. It's a very straightforward procedure. And actually, doing this, it doesn't take much of a time. But there's something they're really aware of, which is a risk that all of us should be aware of. So this bit of gut attached to the abdominal wall can act as a maple, right? The maple that you have at fairs, well, used to, not anymore. But basically what happens, the gut can twist around the two bits that are coming off the abdominal wall and create what we call a volvulus. And this is an emergency, life-threatening condition. Kids do die from this. They can have acute pain because they're often neurologically compromised. Symptoms are not picked up very early. They can't just go to mommy and say, oh, I've got tummy pain. They don't do that. So they present in ED with a severe ischemic lesions, and there's a high mortality when you've got such complication. It's rare, but when it happens, it's a never event, basically. You don't want it to have. So parents need a lot of counseling before agreeing to have a jejunostomy. It's not something that you can lightheartedly ask a surgeon to do. You have to actually to look and see if the benefits are, acceptable. So the risks are acceptable towards the benefits. And sometimes they are, because there's no other way to feed this child. But parents are usually told that this could happen. So you'll find these in your printouts. I'm not going to go through these, just to remind you what kind of tubes you have. So when you see in a letter that a patient has got a PEG J or a MIC J or a Mickey button, you know what they are. Some balloon retained, some disc retained. It's more for your cultural knowledge than anything else. Okay, so we've shown you some cases. We shared our experience. I gave you some facts as much as I could. How do we prevent making mistakes? we're not very good at it. We can't do preventive medicine with these children. We use what is a called cycle of learning, which is what as adults learn by the way. So we make an action, we assess the results, we think, maybe that was not the right decision, and we move on to the next step, and we reassess. Example, child can't eat. We put a nasogastric tube in first. Can he tolerate the volume? Can he tolerate being delivered 200 ml of feeds like the child you've seen in case 3 as a bolus? Yes, it does. No, it doesn't. There's no way for us to predict up front which child will need to move on to jejunal feeds or more complex way of feeding from the other that can't. So you have actually the trial and error. And unfortunately, we don't do shortcuts here. You can't get a child referred straight for a jejunostomy or for a PEG-J. You always need to try it gastric first. You always need to slow down the feeds, and you always need to go to continuous before taking the next step. And I think it does make sense. Happy to discuss it further. It's really common sense more than anything. How do we handle patients? I have a pledge that I go and talk with any neonatologist, any community pediatrician in our country that I meet, and possibly also the neurologist, even if you get in very late in the history of these children. When these babies are delivered and they start developing signs of neurodevelopmental compromising, really, parents are usually told about all the problems that they might have in the future. They won't walk, they won't talk, they won't interact. There's never a discussion about how they're going to feed, how well they're going to actually last on oral feed, how long they might last on oral feed. No one does it. So we often get these kids because they're failing to thrive. And we have to have the discussion as a first people saying, by the way, I think your child needs a tube. And that's difficult, right? Not shying away from what I'm doing, but it's difficult for them after 6, 7, 8, 10 years to come to terms with the fact that they can't orally feed this child anymore. It would be nice to set the expectation right at the beginning. It might happen. It's one of the things that the child might not be able to do in future life. Hope it does make sense, right? And managing expectation is the best way to avoid disappointment and problems in the future. If you're clear up front and you actually give the entire picture, parents are more able actually to come to terms with what's going to happen to the child. And looking after these children, I'm not here to teach you that, but it's about doing a lot of short trials, short interventions, short races, as they say here, to get to a point, and then you lose something else and you have to start all over again. So it's a continuous work, but it is quite rewarding, at least for some of them. Thank you very much. Do you have any questions for us?